from the Center for Biomedical Ethics and Humanities here in the School of Medicine. We're delighted to welcome you all here today. Our program today is titled Life After Death, the Emotional Impact of Adverse Events on Physicians. This is the Jessie Stewart Richardson Memorial Lecture of the School of Medicine, a lectureship which was created in 1999. Interestingly enough, the same year the Institute of Medicine published To Err is Human, its landmark report on error in medical care. Since then, this lectureship has sparked a sustained conversation here at UVA on the sensitive subject of medical error, families, and health professionals. This lectureship remembers Mrs. Richardson, whose untimely death now more than 15 years ago occurred as a result of tragic adverse events in her care at this hospital. Her long career as a school teacher prompted her family to invest funds in medical education so that upcoming generations of health professionals at UVA might know better how to invest themselves in care that has the patient at its heart and to explain and explore without fear medical mistakes when they do occur. This year, as every year, we welcome to our lecture Mrs. Richardson's son, Dr. Don Richardson. Welcome. We acknowledge both the Richardson's family's loss and their generous gift, and also Dr. Richardson's continuing collaboration with us. These annual Richardson Lectures are an evolving conversation on an urgent matter that's now being addressed worldwide. The series has brought to UVA noted national experts, but several times we've also asked persons here at home, clinicians, patients' family members, institutional leaders, to share with us their scholarship, their stories, their strategies for improving quality and safety in healthcare. Such is the case again this year when we welcome back to UVA from just a little distance down the road in Richmond, Dr. Farnaz Gazoni, who's in private practice with Commonwealth Anesthesia Associates in Richmond. Dr. Gazoni will explore with us her research on the emotional toll on physicians of adverse events and poor patient outcomes. The cost is high, both to individual practitioners and to their institutions, where quality and patient safety may be imperiled. It turns out that simply acknowledging these issues can help hospitals and health professionals begin to change for the better. We've asked Dr. Julie Haizlip, who's on my far right, clinical professor of nursing and associate professor of pediatrics, to offer a response about some local efforts to assist clinicians in the aftermath of adverse events and medical mistakes. In what turns out to be a lovely coincidence, our Richardson Lecture this year happens to occur during observance of National Healthcare Quality Week. I'd like to thank the Medical Center's Patient Safety Committee, the Chief Safety Officer, and the Office of Quality and Performance Improvement for partnering once more with the Medical Center Hour on the Richardson Lecture. And again, let's welcome Dr. Gazoni.
Before I start, I'd like to take a moment to thank my dear friend and mentor, Professor Marcia Day Childress, not only for inviting me to be here today, but for all that she has done for me over the years. To say that she changed the course of my life is in no way an exaggeration. More on that to follow. Thank you, Professor Childress, for everything. It is truly a delight and honor to be here with you today and to be this year's Jessie Stewart Richardson Memorial Lecturer. Before I begin, I'd like to tell you a little bit about myself and give you a context for why the Medical Center Hour and the Program for the Humanities in Medicine are so dear to me. I am a proud quadruple who. In fact, some might say that I am a pentuple who, as I am the daughter of a faculty member. My mother, Professor Farnaz Gazoni, has been on the faculty of the College of Arts and Sciences for almost 30 years. I grew up here in Charlottesville, surrounded by and nurtured by the university community. When it came time to apply for college, there was no question in my mind as to where I wanted to go, so I applied to UVA for early decision. As an undergraduate here, although I was pre-med and a bio minor, I majored in Middle Eastern studies and wrote my senior thesis on Ibn Sina, a 10th century Persian physician, theologian, philosopher. I was lucky enough to stay at UVA for medical school and anesthesia residency, and then to join the faculty of the Department of Anesthesia for 4 years. At that time, my husband completed his fellowship in cardiothoracic surgery, and we moved on to Richmond, where we are both working in private practice. Reluctant to leave UVA, I was able to convince my ever-supportive chair, Dr. George Rich, to keep me on as an adjunct faculty. So I'm happy to say that I still have my UVA ties. Given that this is a medical center hour, I feel compelled to tell you about a little detour in my professional trajectory that the medical center hour and Professor Childress played a pivotal role in. After my first year of medical school, I felt disillusioned and somewhat out of place. I had always been, first and foremost, a humanities student. Bogged down and somewhat bored by all of the basic science, I started to question seriously whether or not I had made the right decision. So with the support of not only my loving parents, but also the Dean of Students, Dr. Richard Pearson, who's here today, I decided to take some time off. Not quite sure what my next move would be, I decided to reach out to Professor Childress, who I did not know personally at the time, but who I had seen moderating the medical center hour. I suppose I knew that she could help me find my way back to what had drawn me to medicine in the first place, the humanistic dimension. For the next year, I had the good fortune of working closely with her and found a home in the program for the humanities in medicine. It was this interdisciplinary experience that ultimately led me back to medicine, and for this, I am eternally grateful. We're here today to discuss the emotional impact that adverse events can have on physicians. My objectives are to explore this particular aspect of the practice of medicine. The reality is that adverse events and poor patient outcomes do occur to the patients of all doctors, regardless of subspecialty, regardless of educational and training pedigree, and despite the best of intentions. Sometimes these events are inevitable, as tragedy is a reality of life. Yet worse, sometimes these events are due to mistakes, as human error is also a reality of life. Regardless of culpability, adverse events can take a significant and sometimes lasting emotional toll on physicians. And I'm not even going to broach the potential medico-legal ramifications. I'd also like to propose that these events not only affect physician wellness, but that they may have repercussions that affect patient safety and quality of care. And finally, I want to propose to you that by simply cultivating an awareness of this issue, we are taking an important first step in culture change. I'd like to start by sharing with you a short vignette I wrote just after completing my internship. It tells the story of how I first became interested in this topic. In July of 2005, I was called to my first Code 12 in my official capacity as an anesthesia resident. I arrived to the patient's room to find a young woman no older than myself in respiratory distress. To use lay terms, she was suffocating. Back then, as many of you remember, we immediately intubated patients during these events. Between the time I laid eyes on her and made it to the head of her bed, she lost consciousness. I looked around the room and over my shoulder in the hopes that I would see an anesthesia attending or even a senior anesthesia resident. But I soon realized that it was my time to step up to the plate. It would be the first time I ever intubated a patient without an attending by my side. I pushed the respiratory therapist aside, took a deep breath, and took a look. To my utter relief and sheer delight, I had a great view of her vocal cords and was able to intubate her with ease. After confirming endotracheal placement of the tube, I wiped the sweat from my brow and congratulated myself. Strong work, I thought. My sense of satisfaction, however, soon turned to terror as I watched her turn blue despite my very intervention. Immediately, I wondered if I had mistakenly placed the tube in her esophagus rather than in her trachea. I listened once again to her right lung and her left. I listened to her stomach. I checked again for end-tidal CO2. I even resorted to taking another look at her airway to make sure that the tube was indeed between the cords. I watched as the medicine intern pounded on her chest and listened as the oncology fellow called for another dose of atropine, now bicarb. But not even 360 joules could help her. She had become a blue shell, and finally, there was nothing left to do for her. The code was called. Without hesitation, and within a matter of moments, we all filed out of her room and headed back to the tasks that we had been pulled away from. Without pause, I returned to my duties of caring for the patients in our PACU, the post-anesthesia care unit. Looking back, I realized that I felt obliged, as the seasoned physician I considered myself to be perfectly capable of resuming business as usual. Despite my every effort, however, I couldn't get the image out of my head of this young woman's last moments, and couldn't help but wonder if there was perhaps something I did or didn't do that contributed to her untimely death. Specifically, I worried that despite having double and triple checked, I had inadvertently placed the endotracheal tube in her esophagus. One of our attendings happened to be walking through the PACU and noticed welling in my eyes the tears that I was desperately trying to conceal. For God's sake, get a grip, I told myself on his behalf. But instead, he guided me to a small corridor that afforded a bit more privacy and offered me a fatherly hug and an understanding ear. He listened as I recounted our resuscitative efforts and explained to him many of the questions and fears that were racing through my mind. Had it not been for his compassionate and wise counsel at a moment in time when I most needed it, that code would have been just one of many stressful residency experiences fostering self-doubt, cynicism, and burnout. Instead, that same experience, as painful as it was, proved to be transformative in a positive way. I was reminded of the human dimension of our work. Parenthetically, I must add here that it took me over 6 months to muster up the courage to pull out the young woman's autopsy results. I will never forget the weight that was lifted off my shoulders when I learned that she had died, not due to any medical error on my part, as I had feared, but rather due to a massive pulmonary embolus. In a broader context, the experience alerted me to the potential negative impact that the death of a patient might have on a physician. I started talking to anesthesia residents and attendings, asking them about their experiences with perioperative deaths. I was surprised by the outpouring of emotion. Everyone, even the most unexpected individuals, seemed to have a story that they wanted to share. And as varied as their personalities, the specifics of their stories, and the details of their aftermath, it became quite evident to me that the perioperative death or serious injury of a patient can be an extremely stressful event for residents and attendings alike, often with lasting psychological and emotional impact. Over the course of the next several months, we had 2 intraoperative deaths in our department. I just so happened to be in the vicinity when these occurred. Although not involved in either case, the 2 residents who had been involved were both friends of mine, both excellent senior residents. I remember vividly how terrible they each looked after their respective cases. One of them looked like a pale zombie as he diligently returned the drugs from the said case and simultaneously checked out drugs for the immediately subsequent senior level case to which he had already been assigned. My other friend became literally obsessed with the case he had been involved in. I must have personally overheard him recount every painstaking detail of the ruptured AAA at least a dozen times. He perseverated for months. This was 2005, and at the time, all anesthesia residents were required to present a 1-hour grand rounds to the department annually. The vast majority of these talks were of a strictly scientific or clinical nature. I, with my humanities background and sensibilities, wanted to venture outside of the box and focus my talk on the emotional impact of adverse events. Certainly a soft topic as far as many were concerned. But I was lucky enough to find some mentors who allowed me to pursue this curiosity, and I began by combing through the literature. One study I found to be particularly interesting was published in the Journal of Academic Medicine in 2005. Even the title is fascinating. The paper is called, "This is Just Too Awful. I Just Can't Believe I Experienced That. Medical Students' Reactions to Their Most Memorable Patient Deaths." 65 third-year medical students at 2 New England medical schools were randomly chosen to participate in 60 to 90-minute interviews and to complete a written questionnaire about their most memorable patient deaths. 86% of the students rated the experience as emotionally powerful, with 57% rating the impact of the death as highly emotionally powerful. Students who rated the deaths as emotionally powerful were also likely to describe the event as disturbing. This high level of emotional impact seemed to occur even when the students were not close to patients or had very limited contact with them. In fact, 38% of the students were in contact with the patient for less than 24 hours. Interestingly, the death of the patient caused the students to question their competence. Just like I had after my most memorable death, students worried that they were responsible, either because they had forgotten to do something or because they had done something wrong. The two main messages the students learned throughout their clerkships regarding patient deaths and physician reactions to patient deaths were: one, doctors should not have an emotional response to the death of a patient, and two, that the death of a patient is a failure. A 2003 cross-sectional study of 188 academic internists, both resident and attendings, sought to describe the emotional reaction of doctors to the recent death of an average patient and to explore the effects of level of training on the doctor's reactions. 31% of the subjects rated the event as having a strong emotional impact, and 23% reported that the death was very disturbing to them. Junior residents reported needing significantly more emotional support than did senior residents and attendings. The primary coping strategy used by residents and attendings alike was getting emotional support from colleagues. And this is a theme you will see that comes up again and again across subspecialties. A cross-sectional survey of 74 senior pediatric residents at a large American academic medical center sought to describe residents' exposure and reactions to pediatric deaths. They found that 31% of respondents felt guilty and 9% felt personally responsible for the deaths of their patients. Remarks included statements such as, "I wondered if I should have done more. Did I miss something?" And "I felt I should have done more or been smarter or been luckier." The author of this paper eloquently concluded, "Institutional commitments that allow scheduling of debriefing activities need to occur. Educators need to help train future physicians to recognize and accept their reactions, understand them as a normal part of their work, and acknowledge the importance of talking to others so they can incorporate these concepts into their professional development and utilize these skills throughout their careers." Very quickly, a few other surveys. A survey of pediatric attendings and residents found that 61% of generalists and 73% of specialists perceived the death of their patients as a failure. 100% of residents and 90% of attendings expressed the need for further support in dealing with death and dying. Another pediatric survey revealed that 25% of residents experienced guilt after the death of their patients. And a British survey found that dealing with death and dying was the most commonly reported source of stress for house officers. A recent survey studied the impact of stillbirth and neonatal death on American obstetricians. Despite the specialized scope of this paper, I believe it's particularly poignant. When you think of the life of an obstetrician in very general lay terms, you may think of two things. You think of a physician who gets to bear witness to and be an instrument for the greatest miracle and joy of human existence, childbirth. And second, you think of outrageous malpractice fees. Yes, obstetricians do indeed bear witness to and are an instrument for the greatest miracle of human existence. But they also bear witness to and can even be an instrument for one of the greatest tragedies of human existence, maternal or neonatal death. Malpractice fees are sky high because obstetricians get taken to court when bad things happen to mothers or babies on their watch, oftentimes at no fault of their own, or, yet worse, due to human error. Once again, I'm not even going to talk about the medical legal system or about its practical or emotional ramifications, but I'd like you to consider the emotional impact that being involved in such events might have on a physician or a physician in training. This study looked at the effect of not only neonatal death, but also stillbirth on American obstetricians, and found that 75% of respondents reported that caring for a patient with a stillbirth or neonatal death took a large toll on them emotionally. In fact, 10% considered leaving obstetrical practice altogether as a result. And once again, informal conversation with colleagues was the most commonly used coping strategies. Well, what about the impact of adverse events on anesthesiologists? The British have been looking at this issue for some time. In 1998, a British orthopedic surgeon experienced 2 intraoperative deaths in the same day. As you can imagine, that's a very big deal. During the subsequent fatal accident inquiry, he was cleared of any blame. However, the event sparked a national discourse on how the aftermath of intraoperative deaths should be handled. A prominent British orthopedic surgeon described a death on the operating table as a harrowing experience for a surgeon, and went on to suggest that any surgeon who experiences an intraoperative death is not in an emotional frame of mind to continue to operate. He called for national guidelines to protect surgeons who had experienced an intraoperative death. And in 2001, the Royal College of Surgeons of Edinburgh published guidelines which recommended that surgeons, and maybe even the entire OR team, avoid further elective surgery for the remainder of the day subsequent to an intraoperative death. In response to this recommendation, a survey of British orthopedic surgeons was conducted and found that 53% of respondents had experienced an intraoperative death. 81% of those had performed further surgery that day. While not a single surgeon admitted to compromised functionality, 50% would have liked time off to reflect on the death. A 2005 survey conducted by the Medical Protection Society of the United Kingdom of 600 orthopedic, trauma, cardiothoracic, and general surgeons, anesthesiologists, and OR personnel found that 82% of respondents experienced an intraoperative death. 11% of subjects reported that the death had a lasting effect on their practice. Interestingly, investigators found a tendency of respondents in each group to blame other members of the surgical team and to divide along specialty lines. As for mandatory time off, the majority of respondents felt that it was unrealistic to set rigid guidelines given that the circumstances surrounding each event vary. They preferred that each death be assessed individually with the opportunity to stop work on an as-needed basis. Well, what about anesthesiologists? A survey of 251 British anesthesiologists found that 92% had experienced an intraoperative death. 35% felt a sense of personal responsibility. 87% delivered another anesthetic within 24 hours, and of those, 77% did not feel that their ability to administer anesthesia was compromised. Now, although I understand that 77% reflects a majority, I'd like to point out that this means that 23%, almost a quarter of respondents, did feel that their ability to administer anesthesia was compromised in the immediate aftermath. While 71% of respondents believe that it would be reasonable that medical personnel should not take part in operations in the 24 hours after witnessing an intraoperative death, only 25% thought that this was practical. And I'm going to venture to assume that perhaps this 25% is composed mostly of the same cohort, the 24%, who believe that their ability to administer anesthesia was impaired. Mandatory time off perhaps becomes practical and feasible when you think it's important. One last British study was conducted by the Association of Anesthetists of Great Britain and Ireland, and it was an online survey of over 1,600 British anesthesiologists. They found that just over 80% of respondents had experienced an intraoperative catastrophe. Of those, 40% felt a sense of personal responsibility. Reasons varied from feeling that more could have been done to believing that errors in judgment and mistakes were made. Deaths which involved children and mothers seemed to affect respondents the most. 24% reported that it took a few days to recover from the experience, and 7% said it either took them years to recover or that they never fully recovered from it. 70% continued to provide anesthesia within the 24 hours following the catastrophe, and 10% of these thought that their ability to administer anesthesia was compromised in the immediate aftermath. The comments collected in the survey revealed a heterogeneity of personalities, needs, and experiences. And I believe it can be extrapolated that regardless of subspecialty, we will all have vastly different responses to and needs subsequent to these events. Whereas some anesthesiologists reported reliving the nightmare for months to years, others seemed immune to the experience, with one respondent commenting that anesthesiologists who could not deal with death on the table should consider changing careers. And in fact, many residents reported colleagues who had left anesthesia for other specialties, and many attendings reported colleagues who had gone into early retirement. So, months after I had presented my findings to the department, I was approached by one of my anesthesia attendings, Dr. Marcel Durio, who suggested that I write a short piece on the topic for the Anesthesia Patient Safety Foundation newsletter. He was kind enough to mentor me through that process, and then a year later, he mentored me through the process of writing and publishing a review article on the topic. Then we decided to conduct a survey studying the impact of perioperative catastrophes on American anesthesiologists. Such a survey had never been conducted in the United States. Our department chair, Dr. George Rich, was kind enough to enthusiastically support and fund this project, which was selected as the cover article in the March 2012 issue of Anesthesia and Analgesia. We hypothesized that 1, the majority of respondents would have experienced at least one perioperative catastrophe. 2, the majority of respondents would report a high level of emotional impact after the death or serious injury of a patient. 3, that the majority would believe that their ability to administer anesthesia was not compromised in the immediate aftermath of the event, but that 4, in the future, most would like time off to reflect on and recover from such incidents. First, we set out to develop our instrument. Given that neither I nor anyone in our department had much experience with survey research, we decided to join forces with UVA's Center for Survey Research. We worked closely with the staff of the CSR, consulted with a psychologist with training in PTSD, and even consulted with Dr. Mike Wee, the British anesthesiologist who had headed up the AHEBI survey I discussed earlier. We divided the questionnaire into 4 sections. In section 1, demographics, we sought to determine items such as gender, number of years in practice, and practice setting. In section 2, experiences, we asked questions such as, what specific events would you include in the category of catastrophic? We also sought to determine the percentage of respondents who had been involved in what they considered to be a perioperative catastrophe. In section 3, a memorable event, we asked participants to focus on the single adverse event that was the most memorable of their career and sought to learn about the impact of that event on the respondent. Finally, in section 4, your opinions, we asked respondents how they thought the aftermath of adverse events should be handled. After conducting a pilot study, we sent our postal survey to 1,200 randomly selected members of the American Society of Anesthesiologists. 80% were active members and 20% were residents. We received 659 responses, 56% response rate, of which 15% were residents. We found that 84% of respondents had been involved in at least one unanticipated death or serious injury within his or her entire career, and 62% had been involved in at least one such event within the past 10 years. 570 respondents participated in the most memorable event portion of the questionnaire. Some interesting findings about this most memorable case. Only 67% involved patient death. So clearly other catastrophic events, such as, let's say, MI or stroke or difficult intubation, take a toll on anesthesiologists. Only 46% of these cases occurred intraoperatively. And further, only 40% felt that this most memorable case was definitely or even probably anesthesia-related. We also found that respondents felt responsible for the event, even if they believed that they could not have prevented it. 52% felt the catastrophe was definitely or probably preventable, and among those, 76% felt personally responsible. Of respondents who felt the event was not preventable, 64% felt personally responsible. Thus, the majority of respondents felt personally responsible whether or not they believed that the outcome was preventable. Regarding this index case, we found quite a high degree of emotional impact. Over 70% of respondents indicated that they experienced reliving the event, guilt, and anxiety. Over 60% experienced fear of litigation and depression. And 50% experienced sleeplessness, fear of judgment by colleagues, anger, and professional self-doubt. 12% considered a career change, and 5% turned to use of drugs or alcohol. 88% of respondents indicated that they required some amount of time to recover emotionally from the event. Emotional recovery was not specifically defined, but was left open to respondents' interpretation. When asked how long it took them to recover from the index case, the most commonly selected time frame was 1 week at 21%. However, we were surprised to find that 19% of subjects indicated that they never fully recovered from the experience. We found no statistically significant difference in recovery time by gender, number of years in practice, the ASA class of the patient, that's how healthy they were before the case, or whether or not the catastrophe was believed to be preventable. When asked about care provided in the first 4 hours subsequent to the index case, to our great surprise, 67% of respondents indicated that they believed that their ability to provide anesthesia was compromised to some degree, with 32% feeling compromised a lot during this period. 51% of respondents believed that their ability to provide care was compromised for an entire day, 27% felt compromised for an entire week, and 16% felt compromised even longer. However, only 7% were given time off, and of these, 95% found that time off to be helpful. So, to summarize, we found that a majority of anesthesiologists had experienced at least one perioperative catastrophe over the course of their career, that these events often had a strong and lasting emotional impact, and further, that a majority of respondents perceived that their ability to provide care in the immediate aftermath of these events was compromised. A majority. Pretty powerful results. To close, I'd like to share with you one more vignette I wrote. It tells the story of the first and only perioperative catastrophe I have been involved in to date. Patient FG was a 28-year-old G1 at 40 weeks exactly, who presented on July 24th, 2006 with spontaneous rupture of membranes. Incidentally, both she and her husband LG were residents. He in our department of surgery, and she in our own department of anesthesiology. She labored all day, and at approximately 5 p.m., she was declared fully dilated and fully effaced. But because her baby had started exhibiting signs of distress, her obstetrical team decided to bring her to the OB/OR. Although they believed they could safely deliver him vaginally, they wished to do so in the OR in case they needed to emergently move to cesarean section. What followed was a series of events which created the proverbial perfect storm. After 20 minutes of pushing and 2 unsuccessful attempts at a vacuum-assisted delivery, the decision was indeed made to move to cesarean section. By this point, a thick and ominous cloud had fogged up the room. Clearly, things weren't going well, yet no one wanted to admit it. The words shoulder dystocia or stat were never uttered. Instead, everyone kept reassuring the parturient and her husband that everything was fine, great in fact. They kept commenting on all of the baby's beautiful black hair, going so far as to send a nurse out to the family waiting room to tell the expectant grandparents about the baby's thick, dark locks. The surgeons took their time prepping and draping, and the anesthesia team likewise chose to dose her epidural with lidocaine, a slower-acting local anesthetic, delaying surgical incision by a few more moments. FG and her husband could see and feel that ominous fog, perhaps more clearly than anyone else in the room, and were already braced for the worst when the time of birth was announced and their baby didn't make a sound. The silence was deafening. They tried not to watch as the NICU intern and resident attempted to resuscitate their son, but couldn't help but hear them call for more epi, more chest compressions, more assistance. Several hours later, they met their son Paulo for the first and last time and held him as he took his last breaths. His traumatic birth had caused an anoxic brain injury incompatible with life. As you may have guessed, I was that very parturient, LG, my husband Leo, and Paulo, our first child. After Paulo passed away, I didn't think I would ever continue with the ironic research project I had embarked on before his death. How could I have missed the point so entirely, I wondered. But although it took several months, I did eventually feel compelled, in fact, to return to the project, both in my capacity as a physician and a bereaved mother. I must add here that I came back to this project not on my own volition. It was about 8 months after our baby had passed away. I was pregnant again, and I was covering nights in the surgical intensive care unit. It was a pretty miserable time in my life. One night, my friend and mentor, Dr. Marcel Durio, paged me and said he needed to talk to me. He came up to the unit and suggested that I write an article on the topic for the Anesthesia Patient Safety Foundation newsletter. I expressed my hesitation, but he encouraged me to move forward with this project and promised to help me with it. Looking back, this was a pivotal event in my recovery, in my career, and in my life, and speaks to the power of mentorship and friendship. As physicians, we owe it to our patients and their families to take the wrong turns we take as physicians seriously, to learn from them, to grow from them, and ultimately to be better physicians because of them. This is how we can honor the true victims of medical mistakes and catastrophes, the patients and their loved ones. We owe it to our subsequent patients and their families to think seriously about whether or not we need time off after an adverse event. And finally, we owe it to ourselves to make sure that support systems are in place to prevent lasting professional and/or emotional sequelae after a medical catastrophe occurs. I believe that incorporating this issue into medical, residency, and CME curricula is of the utmost importance. I realize that this soft topic must at times take a backseat to the acquisition of information. I understand that our students and residents have exams to take, boards to pass, and patients to take care of. But we must not lose the forest for the trees. We want to train not only proficient and knowledgeable doctors, but also compassionate, kind, happy, and healthy doctors. Doctors that like their jobs, connect with their patients, and find meaning in their work. To achieve this, I'd like to propose we must not only teach the science of medicine, but also cultivate the art of medicine. Studying the art of medicine will give a human context to many of the seemingly mundane facts and figures that need to be memorized, the protocols that need to be followed, and the procedures that need to be mastered. While studying the art of medicine certainly entails such noble and lofty objectives as cultivating impeccable bedside manner, developing meaningful rapport with patients and colleagues, and mastering the art of the open-ended question, it should also entail an awareness of the reality that bad things will happen to your patients, and a discourse on what the aftermath might entail and what the aftermath should entail. We all know the infinitely profound and timeless Hippocratic Oath. First, do no harm. And Hippocrates was right. We as physicians need to be fully committed to preventing adverse events by studying diligently, training rigorously, and then practicing vigilantly. But we should also be committed to handling the aftermath of adverse events when they do occur with compassion, wisdom, and vigilance. Furthermore, we need to further explore the possibility that quality of care and therein patient safety are impacted after adverse events occurs. Perhaps this too falls under the umbrella of the Hippocratic Oath. Finally, I believe that reflecting on this issue and talking about it, by taking it seriously, we will be far better equipped to handle adverse events when they occur, and we will ultimately be better able to serve our patients, their families, our colleagues, and ourselves. Thank you.
thoughtful discussion of a challenging and important topic. I think that all of us in healthcare can appreciate the truth of what has just been said. I know that certainly as someone who practiced pediatric critical care for 10 years and experienced the deaths, both expected and unexpected, of my patients, it certainly resonates with me. I think that while we'd like to believe in practicing healthcare, we're superhuman, and we can do so when we're sleep deprived, when we're sick, when we need to keep going. But I don't think we can deny that we do have an emotional response to the work that we do. And in those situations where we aren't allowed the time to react to those, we do what has to be done. We suppress our experience and our emotions, and we keep going. And we do that out of necessity, but also because we have a commitment to the next patient as well. So despite being distressed, we carry on, and most people do not reach out. And even when there are sources of support available, we don't always take advantage of them for exactly those same reasons that Dr. Gazoni just mentioned, that we're afraid we'll be judged, that we're afraid that we've done something wrong, and it's just entirely too painful to discuss. I think it's important to go back to something that was in the study of the obstetricians, that 87% of those individuals felt that they needed to speak to a colleague and that helped them in the moment. There seems to be tremendous solace in speaking to someone who actually can understand the intricacies of the case, can understand where you might have doubts or concerns, and who can give you another detached and yet very relevant perspective on what has just happened. And even if the conclusion is there was something that was done wrong, or there was something that could have been done better, there's then an opportunity to learn and to share and to pass that on to future generations of clinicians. I think it's important also, although the topic of today's talk is not the medico-legal ramifications, it's important to consider that what we are told not to do when we have one of these experiences is to talk to others about it, because those conversations can be discoverable. That advice is well-intentioned. We certainly don't want to get ourselves in greater trouble than we already might be in. However, it stifles our ability to communicate with others, to get the support that we need, and to heal. And I think I would also like to mention a study that was done by Dr. Peggy Pluzogan and her colleagues Justine Owens and Natalie May, where they interviewed physicians who had been involved in medical error. And while we're not specifically talking about medical error today, I think it's relevant. They found that sharing one's story and getting support was one of the critical steps in moving away from post-traumatic stress and toward post-traumatic growth. So I'd like to tell you about a couple opportunities that we are developing and have developed here at the University of Virginia in the time that I've been here to address some of these emotions that we tend to suppress or that we tend to look away from. The first is Schwartz Center rounds. Schwartz Center rounds are a program from, not surprisingly, the Schwartz Center, which was founded in memory of Kenneth Schwartz. Ken Schwartz was a healthcare attorney who at the age of 40 was diagnosed with metastatic lung cancer. He wrote a beautiful and poignant article in the Boston Globe that talked about how the kindness and compassion of the people who were caring for him made the unbearable bearable. He talked specifically about a nurse who held his hand before surgery and an And when he died, he wanted to ensure that there was something that could help physicians and nurses and other clinicians move away from burnout and maintain compassion. And so the Short Center Rounds provides a forum where we as clinicians have the ability to discuss these very difficult cases and how we are affected by the work that we do. And we don't always talk about catastrophes, we don't always talk about deaths, we don't always talk about mistakes. But it's a place where we can hear the perspectives of individuals who experience different dimensions of the patient's care, and where we can gain a greater understanding both of ourselves and those with whom we work. And it is a place to find comfort in the shared experience of clinicians. We're currently in our 3rd year of Short Center Rounds here. We've gotten an enthusiastic response, and I'm proud to say that we've had at least 200 people attend each of those sessions. Clearly, there's a need. The other program that's currently under development that I want to make sure that you're aware of is the peer support program. This is a program that Dr. Pluzok and Dr. John Shorley and I have been working on since 2009, but it's finally coming to fruition. And we have worked with a number of amazing clinicians from different professions as well, and also our legal colleagues. It's now approved and is going to become part of the Be Safe catalog of services, I suppose. We want to be able to deal both with medical error and also with catastrophes or unexpected bad outcomes. And our vision is that when the first call goes to quality and patient safety, that the support network is also activated, and that's the part that we're working on now, the infrastructure. We're currently training physicians, nurses, therapists, anyone who would like to be a part of this support network. And we will have the ability to contact these people immediately in the aftermath of one of these situations. Our goal is to provide a way that people can debrief safely and with someone who can understand the intricacies of what they've just experienced, but with as much legal protection as possible in the situation. So this will all be coming out to you in a more formal presentation in the not too near future. But in the meantime, should anyone be interested, we would love to have you as part of our group, or if you need our services, we are already here. I think that there's value in acknowledging that what we do is both challenging and rewarding, but in tragic circumstances, it can be completely devastating. I encourage you to take advantage of these forums that we're developing here. We owe it to ourselves and our community to provide support for one another. Thank you.
I'd like to thank both of our speakers, and we have time for comments and questions and conversation with you for the remainder of the hour. I would ask you, if you have a comment or question, to please identify yourself at the start of talking, and please do wait for a microphone so that your comment becomes part of the record of the program. Again, we have a couple of mics to bring to you, and I'd like to thank both Dr. Gazoni and Dr. Haizlip for their presentations, which contained a lot of thought and a little bit of courage. So thank you. Who'd like to start? Okay.
Dr. Gazoni, always a pleasure to have you here. And Dr. Haizlip, thank you for getting those programs up and running. I think that's important. My question is for you, Farnaz. Philip Smith, Department of Surgery. There are different circumstances in which we have catastrophes and deaths, and the patients are of a different nature. You mentioned in one of the studies, as well as in a personal story, that perinatal and obstetric catastrophes seem to have a higher impact. But in other situations, how much impact does it have when it's an expected death versus a patient who has an outcome that's expected to be great. In other words, the patient who comes in extremis and has a bad outcome versus the patient who comes in for something elective and ends up having a catastrophe or death. Is that known? I mean, the sort of obvious observation is that the one is more damaging to the providers than the other, but has that been looked at?
Well, thank you so much. I think you're right. Intuitively, it would make sense that a patient who was healthy, a patient who's having elective small surgery, should have take more of a toll when things go back, because we don't expect that to happen. It becomes much more of a surprise, and I think the sense of culpability may be higher. In our study, we were not able to find any association between ASA status, so an ASA1 patient is someone who's completely healthy, and an ASA4 is someone who's extremely sick. And we were not able to find a correlation or an inverse correlation between the preoperative health of a patient or whether or not the surgery was elective, urgent, or emergent, and the impact that it had. And I think, again, it might have to do with the circumstances surrounding each vary, and also our personalities are also different. And that's one of the things that make this so tricky and why it's hard to come up with blanket strategies, because, again, the circumstances surrounding each case is going to vary quite a bit.
I'm Melvin Jetson, one of the staff chaplains here at the hospital, and I work with the bereavement services. And we did a small survey one time of just our bereavement coordinators, finding what they were needing in support as we were expecting the bereavement coordinators on our different units to help the staff in our areas. And it surprised me, but when I got back from the survey, one of the nurses, bereavement coordinators from CCU, who had always worked very powerfully with families, as I joined with her to work with families when their patient was dying. And on her survey, she answered, "Help us to know how to deal with the emotions." And when I asked her further about it, it wasn't only the family's emotions, it was their own emotions. So it parallels what you're saying here. And having also been a part of POM and then CPD, realizing we do a lot of teaching of science, but when does emotional training take place? And what I liked about what you're saying is the talking to each other. Maybe in that talking with each other, that's when the emotional training in this very important work that we do starts to take place. Maybe we need to be just more intentional about emotional training.
Do either of you want to comment on that? I will say, having been to some of the Schwartz rounds presentations, one of the things that strikes me is that the kind of conversation that occurs in that forum by the panelists, but also by persons in the audience, begins to model something of a conversation that does include emotion and helps to give people a vocabulary and a sense of permission to go there in their reflections. And I think that's been an important purpose for Schwartz rounds for us institutionally, to give us permission and to help us find the right words.
Karen Knight. Oh, thank you. I was just wondering, how do we reconcile, though, the fear of legal repercussion and the need to discuss and debrief? You raised that as an issue, and I think it's a very real issue. You know, whether those conversations get pulled back into a court case. So how can the institution help that process?
So that question is the reason that it's taken us more than 5 years to get this program off the ground. So the way that we are trying to do this, to offer the most protection that we can, is by housing our program under the quality and patient safety umbrella. In Virginia, the precedent has been set that most things end up being discoverable. But what we intend to do is to have this support network that reports back only whether or not they have worked with someone, not the details of any of the cases. And so we will be able to have some data about how much we are able to do, but not written specific data about any of the cases with which we interact. And so that's the way that we are trying to provide security in that regard. However, I'll tell you, both from personal experience and experience of others with whom I've worked, when you have one of these distressing situations happen, you talk about it because there's no other way to get through it. And so what we're trying to do is at least put it in a context where we can offer some protection.
I'd like to make a comment, but I don't wish to be recorded.
Oops. Why don't you save it till after the program? And you can talk with them individually. Do we have anybody who's got a closing question? Yes.
Hi, I'm Rosie Bennett. I'm a graduate nursing student. And you talked about that it's important to, we know it's important to discuss when something like this happens, but should it be formal or versus, you said just talking with other people, but is it something, do you know that leaders should make a formal discussion of all those who are involved in that case? Is that a worthwhile thing, or has that been most people not going to be really involved and desire to even be involved in that conversation?
That's a really good question, and I think we need further research. In our study, I didn't have a chance to discuss that. We actually found that participants who had attended morbidity and mortality conferences and interdepartmental quality assurance meetings had a harder time recovering from the event. And because we don't know why, was it that there was more culpability? Was it that the circumstances surrounding the case made it so, or was it that the M&M itself caused them to feel worse about their performance? So we really don't know. And I think that what the studies showed is that talking with colleagues, and we don't know in which capacity, but I assume it would mostly be in an informal way, proves to be therapeutic, because as Dr. Haizlip said, you want to understand the specifics of the case and the intricacies of the case, and having someone who understands the science and can say, I would have done the same thing, or is extremely helpful. What we need to do as far as M&M, different kind of groups, we still don't know. I also want to say I went to Beth Israel Deaconess Medical Center about 2 years ago and gave this talk, and the residents there, they started this grassroots movement, which, I think culture change is a huge piece of this. And the residents got together and they decided to start a support group. And they made this system where as soon as someone was alerted that there had been an intraoperative catastrophe, the support group was contacted and a single person was chosen to be that particular resident's contact person. Kept an eye on that person, offered to help, and served as a liaison between that resident and the program director. And I think those grassroots things, culture change, that's really what's going to make a big difference.
I will avoid discussing specifics, but I will tell you that I think it's an important aspect of this, not only to receive support and to give support, but it's an essential aspect of it to see what needs to be done or learned or developed to prevent recurrences. And I think that's an equally important aspect of the response to disaster.
I agree wholeheartedly, and I would mention that in the study that Dr. Pluzogan and her colleagues did, that was also found as one of the critical factors in helping people move forward.
I think it's nice that we've ended